Very nice to see you again, Noel. I'm really missing to be there with you. I followed a very great session previously, and I think my talk is going to be complementary to that. So, should I start sharing my presentation?
Yes, please.
Yes, thank you. Okay, so we're going to talk about the canalization of the calcified chronic total occlusions, which is essentially an extension of the previous session where all the difficult or the different aspects of calcium treatment or contemporary aspects have been addressed. And essentially this talk is going to put very slightly the corner of where all of these coming together into the CTO and why they're more relevant, even more relevant, I would say, not more relevant, for the CTO interventions. And for that, I'm going to review the literature for you. And I'm not going to go into extreme detail, but if you see the different, they have been developed in the CTO PCI, different predictive algorithms of success or failure. That's point one. They're called the well-known scores. And here you see an overview of them, which is the different scores. There are more than that, but the major of these, the JCTO score known as from the beginning of 2011, the progress CTO score, the discharge score, and the Castle score. These are 4 predictive score of success or failure. And there are some more, and there are also CT developed scores. But the matter of the point is that if you focus on these scores, you will find out that the majority of them, they are considering calcification as one of the major parameters of success or failure. It's an adverse predictive parameter for success. The more calcium, the more difficult the intervention, and the less the success rates that you have on these. The progress CTO score doesn't contain calcium here, as you will see, but this is a score of the past. And the next figure I'm going to address as to why this has been changed, because although this is a quite recent publication, it's including the initial data from the progress CTO score of 2016, which has been revised. In the last 2 columns here, you will see complication scores, and we have 2 major complication scores developed again from the progress registry from the United States. Although it's a United States registry based by Manos Brilakis, it's essentially international registry. And you see that also here, as to the initial progress CTO calcium, it doesn't come as an adverse parameter, but this has been changed, and the Open CTO registry that essentially have developed the Open Clean CTO complication score. And again, you see that calcification is one of the major parameters of failure. If you take what I was telling you before, referring to the complications, you'll find out that in the revised and the very recently revised progress CTO score, referring to complications first of all, and you will see that severe or moderate to severe calcification anymore in the 22 version of it, not in 2016, both on major adverse cardiac events, but also, very importantly, for mortality and for pericardiocentesis. You will see that moderate to severe calcification, and we're always talking about the field of CTOs. Calcification is an important parameter predicting complications. MACE, mortality, very importantly, in pericardiocentesis. It doesn't come as a predictive value for the acute myocardial infarction. And of course, in the other complication score, again, as you will see, that calcification is also a very important parameter for developing complications. Here you see the initial parameters from the progress CTO complication scores. Very recently, in 2-3 days ago, the progress CTO perforation score has been published. And you see that again, calcification moderate to severe increases the risk of complications of severe perforations, not complications, of severe perforations by 85%. Of course, this is an overpublished registry, so you have the previous version pericardiocentesis score, you have now a perforation score, but the bottom line to the topic of the presentation is that severe calcification is a very important parameter into the CTO-PCI, both predicting reduced success rates and increased complication rates, and not only perforations, but also mortality and major adverse cardiac events. Here, to put things in a very even broader perspective, there is a publication again coming from the Open CTO registry, which what it says is that CTO-PCI is an expensive procedure, almost the double of the non-CTO-PCI. And if you put into perspective the complications that they might arise there, they add in total another 30% total the total cost, making the procedure even more expensive. What does that mean? That addressing calcium correctly into the CTO-PCI is a very key parameter in three aspects: to increase success rates, to reduce complication rates, and to keep the procedure into the minimal cost without jeopardizing the previous two parameters. I'm going to share with you the two cases from the last week. They're not anything spectacular as a case, but they show the everyday life of how complications can, how calcification can affect the CTO-PCI. This is a 77-year-old male, came 2 days ago in the cath lab with an NSTEMI. And the right coronary artery was pretty much okay. And you see here that there is an occluded LAD and there is a TMO flow into the circumflex coronary artery. As an NSTEMI, it was not entirely clear what might the culprit vessel be. But anyway, when you see that there is an occluded LAD, conceptually, a wire is going there, but very quickly we find out that this is not a fresh occlusion. You can see a run-through wire buckling over there. So the next step is to fix the circumflex, and it was done with DEB, and into the ostium of this marginal branch there was some more additional dilatation done fixing this under expansion. So the patient, from that, it was obvious that he had calcifications in his coronary arteries. They're not entirely clear into this, and that's another key message, that calcification detection only by angiography is not very accurate, and someone could rise drive into surprises. You see here a Gladius EX wire finally, with some difficulty, finally was able to address and reach the distal true lumen of this LAD, but then 8 different balloons including the best-in-class failed to cross, and Sapphire Pro, this is one of the 4 that they ruptured into this LAD. You saw the contrast penetration into this septal branch. We kept on pushing, but you see that the catheter is buckling. Anyway, I am going to address that very quickly. We removed the other wire and I took a Sion black wire, knuckled it proximally, because sometimes bypassing, or not bypassing, but let's say suboptimizing the course of the calcified part might help the access and crossing. But as you will appreciate, this didn't even help in this case. So essentially, we established that the LAD was not the culprit, and we staged the patient to come for ablation. As far as wire access was afterwards considered as easy. This is another case that came on the table, stable angina. It was catheterized, and you see that it has this marginal branch. Again, it doesn't give any huge feedback of terrible calcification. The vessel is sizable, so we decided to take on it. And dual lumen microcatheter was used in order to address the side branch. And you see here immediately that a Gladius EX wire made progress into the CTO, but you see the buckle, despite the backup of the dual lumen microcatheter. Anyway, this was the maximum penetration that it could do, so it changed that to the Turnpike LP. The Turnpike LP was able to progress into the lesion, as you can appreciate here. The Gladius CX was exchanged to an Gaia 3 wire. That finally, this wire with some manipulation, I think, addressed the distal vessel, as you will see here. All of this fluorostoring. Anyway, the Gaia 3 went into the right place distally. And the microcatheter afterwards, it was advanced. You see that there was not easy, but not with enormous problem. And the lesion was predilated with a 2O balloon, no problem. It gave the good feeling that everything is expanding well. This is the injection after that. And IVUS imaging with an OCT was tried. But you see that the microcatheter, not IVUS, OCT imaging, but you see that the catheter is not being able to be advanced. And 2.5 non-compliant balloon is coming, and you see that the dilatation of the balloon comes back. So we start understanding that there might be an issue over there. And here the 2.5 anymore has a waist that is not fully possible to be expanded. And you can appreciate that the same thing is happening with a 3O balloon. You talked about all these things. This is the IVL balloon that is not possible to be advanced, and that's one of the things that has been addressed by the previous speakers, that essentially all of these devices are complementary rather than competitive. And Dr. Gelev clearly said it, that in 50% of the cases we have to rotablate before we're able to deliver the IVL. And that's exactly what happened in this case after exchange the wire. And this is 1.5 Burr. In order to be able to ablate, it was not possible to be advanced very distally, and you can clearly see here, but deep enough, the patient developed some bradycardia and hypotension, so we didn't complete it, but it was enough to allow the IVL to pass, and then to fully expand. The additional dilatations were done with a scoring balloon, and finally the stenting led to that satisfactory result that was confirmed by IVUS, that there was a round expansion of the stent. You see around here the spots of calcification that created the entire problem over there. So if I do this case cut down, and you'll see that initially you get the feeling you need wires that in the high range of medium, around 5-6 grams to cross, with dual lumen microcatheter supported, NC balloon resistant lesion, LOTA Pro preparation, IVL scoring, NC high balloon post dilatation and imaging in order to succeed. So all of these devices finally they aim into the right direction in my view, because, and I didn't want to show cases of that, during the course of the evolution of the CTO PCI, we have been in this to subintimal pipe bus of the very calcified lesions. So essentially we're not able to by no means to treat them properly in the past. So essentially we were doing subintimal connections around them, and we have been creating calcified nodules to be suppressed by subintimal stenting. I do not recommend that, and that's why I'm not showing you these cases anymore. Because we do have the tools to address calcium properly in the CTO in order to increase success rates, but more importantly to me, to reduce complications. Because if you take in these kind of lesions that I showed you, OPM balloons, and you dilate up to 60 atmospheres, you might open them, but there's a good chance of around 10-15% that you might get detrimental complications referring to perforations. That finally is better to spend the money into proper calcium modifications rather than treat complications. Again, I showed you these slides yesterday, but to me they're very important because you see that referring to the other comorbidities, calcium, as you can see it here, referring to the complexity of the coronary artery disease, remains of the top of the pyramid far more than the complex left main stem. And I think is today, including left ventricular assist devices in patients with suppressed LV function, calcium treatment in combination with CTO, they're remaining at the top of the pyramid. And the combination of CTO and calcium, I think, is the very edge of the perfection into the coronary interventions as we speak today. Thank you very much.
Thank you, George. That was really an excellent presentation about the calcium, which seems, in my view, one of the strongest predictors of failure in CTO and how we can address it. Any comments, questions from the audience? I was going to ask you, how often we need to do this subintimal tracking in your let's say in your practice in order to be successful in a very calcified and, let's say, wonk lesion. Finally, this is something which is happening very often, especially with the retrograde approach.
Yes, what I would say is that essentially when you do ADR or dissection reentry or antegrade or retrograde, we know that today is around, if you take that the retrograde procedures on average are 30% of the total CTO burden in all CTO techniques. So more or less, both in the European and Japanese registers, but also you will see that around 25% in the American side more is retrograde. Around 50% of these are dissection reentry, whether they are including retrograde dissection reentry or they're including antegrade dissection reentry. So if we consider that essentially if you take out of this 30%, 15% in calcium is a severe problem in around 20 to 30% of these cases, I think still this calcium bypassing, intentional or unintentional, the majority of the cases become unintentional. People are trying to cross in the most right pathway. But sometimes, whenever you have this chunks of calcium, the wires are deflecting and they're dissecting, then you go around. More intentionally, you do it in the proximal cup when it's unbelievable calcified, and then you have to bypass it in order to penetrate to get into the body of the occlusion. I would say that the total incidence, if you put them all together, is around 5 to 8%. And in these cases, essentially, is what you see in these databases that I told you, because we realized calcium, we have been passionate in the CTO PCI for a very long time about success rates. But we reached at the top of it. 90 plus is what you will see for now and for the future. I don't believe that this will change. But the big battle to make the procedure more acceptable is anymore in the complication rate. And under the pressure of the finances, if you really do this very aggressive, I didn't go into that, but because there is an interreaction you see into this progress CTO complication rate, you will see that the dissection reentry techniques are getting, calcifications getting 1 point as to the total score, but the dissection reentry technique get another one, and the retrograde techniques another 2 points. But quite a lot of that, if you cut it down into the reality, why do you do DR or you do retrograde DR? Because of calcification. So the complication rates are increasing when you do these techniques. So I would say that we should avoid them anymore, mainly for that reason, and not because of the very long-term bad or adverse outcomes after stenting.
Thanks, George. There is another question.
Okay,
from
George, I'm Plamen Gatsov talking. What about the CT coronary angio before such procedures with very calcified lesions? Is it helpful for you to do CTOs, and how often do you use it?
Imaging is a very big thing anymore, and I think again you addressed it this and yesterday also. Even in very wealthy healthcare systems, Yves Bar clearly said that hypocedin is not reimbursed in France today, so they're treating left mains based on the experience that they have developed over time. That shows that if you have a lot of experience, you find you might not need it. But again, consider two things that. First of all, I don't believe that they are really increasing success rates, and that's point one with the contemporary techniques. The second thing is that in my practice, I apply them only in cases that I fail or whenever I don't understand the angiogram. And in the third time, I mean, even if you see the calcium with these kind of procedures so extensively, then you can see it from the angiography, and I don't believe that it will play any very important role, at least for success rate. And during the procedure, you understand the problem without that. So, in my view, take the example of the case that I showed you. I wouldn't have done in advance an MST in the second patient that was successful. But if I failed, yes. So I don't believe that the MST is the solution to the problem. The solution is what you discussed over these 2 days, and I see that the meeting is focusing more and more in the right pathway of really treating the calcium in a more appropriate way, and then that is what's going to improve outcomes.
Okay, thank you.
CT can be very useful, but especially as second modality of imaging, and I think the most important thing that gives you the CD information, the most important is when you have a bigger course of the vessel, because otherwise you can see the calcium easily if it's heavily calcified. Of course, doing that you can get some idea of the distribution of the calcium, and it can in a way navigate how to what wires to use. But we have done some cases in which CT was quite useful. Just give an idea what is the course, and that makes you much more.
For that I agree. That's what I told you when you have cases of ambiguity. But I think the question was referring mainly to calcium modification, prediction of calcium. So it's one thing about how you use the CT for improving success rate in certain cases, and it's another thing of how you, if this can be really helpful on providing you clinical relevant information for the treatment plan based on calcium. No doubt, because I didn't mention that, it has a higher sensitivity of really seeing the calcium compared to coronary angiography.
Any other questions? If not, we are really
thank you very much.
Thank you very much, George, and I hope we are going to see you at the wife cases and tomorrow at the
I'm not going to miss for a second time the wine testing. Thank
Unfortunately,
you
yes.
Thank you to everyone. Thank you. Bye.
See you later.
Yeah,
so the next speaker will be Dr. Rigatelli, and actually I was the man who decided the name of this lecture for you.
Yeah, when I saw
just
it,
to challenge your creativity.
Yeah, when I saw it at home, I think in Italian I think Strozzi. Meno male che eravamo amici. It means in English it sounds like assholes, fucking Bulgarian brothers. But okay, it's my strange speech of today. But then when I realized the title, I started to think that probably it make a good sense to have such kind of presentation, because you cannot imagine how many places around the world are, how many places around the world someone have the strange idea to build up a cath lab without any knowledge of what you need to build up a cath lab. So maybe that you, in future, I speak for young people, you find a place to work in a very strange, ugly, and wild places where you not have anything to work. I remember the case of a university in the middle of the jungle in Vietnam, where the whole shield for all the stuff for the cath lab was a box, a paper box where some visitor put some catheter, some guide, some stent, and even some IVUS catheter. And I get there and they, oh, good, at least you have IVUS, but we don't have any machine. So we had the catheter, but not the machine. All right. So in Italy, for this purpose, the GISE Society is the society, Italian Society for Cardiac Intervention and Angiography, invasive cardiology, recommend to have a rotablator in every cath lab. And this is also necessary to start an interventional cardiology program in Italy, at least in Veneto region, the region where I live and I work. No recommendation yet are in place for IVL in order to obligatory have it in the cath lab to start a program, obviously. However, sometimes a rota or IVL can be unavailable for a number of different reasons. In Italy, for this last 6 months, we experienced a very late arrival of the device we ordered, just because I don't know why, the war in Ukraine, other stuff, I don't know. But when I started my new activity in my new cath lab near Padua University, we didn't have yet IVL. We have some rota, but the program was not fully accomplished, and it is fully accomplished now. So we have this case, an inferior STEMI, severe calcification, subocclusion, diffuse disease. And my day started badly. I don't have a rota, I don't have IVL, the patient needs to be treated somehow. So, in my view, first of all, I pass a wire. I started with a very soft wire, Wilsper, LES, cyan blue, eventually cyan black. Then I pass an over the wire balloon, 1.0, and I change the wire with a BMV heavyweight or Versatone. If I cannot get through, I try to pass a CTO microcatheter, and then I change the wire with a more supportive wire, like the heavyweight or the Versatone. Remember that you need some support. If you expect a problem in crossing calcified lesion with the balloon or the stent, support is a good thing also if some complication occurs. And then you have to delete. My option, delete and pray, is a risky behavior, but sometimes works. Try to be somewhat organized. Definitely better, but sometimes not work at all. Turn down patient and refer to other centers is a possibility, but sometimes you not have the possibility to turn down the patient. And my choice is the combination of 1, 2, and 3. Best option, so let's try. In my mind, if I can pass an IV or no CT, is not too bad. I mean, how much calcium, circumferential, partial, I don't waste too much time because you listen Akiko, and she gave an extremely meaningful lecture. If you have a circumferential deep, circumferential intimal, sectorial deep, sectorial intimal, what to do? Just to be quick, in case 1, an OPM balloon and then a SCORI balloon, keep attention for rupture. In case 2, circumferential intima, NC balloon high pressure, keep attention for dissection. In case 3, sectorial deep, NC balloon normal pressure, that is the same strategy for sectorial intima. Then stenting. Then you have 2 choices. Wait or defer for IVL in case of underspansion, or finish the procedure because the patient is and the stent went well. The problem is when you cannot pass an IVUS or an OCT. That's a really bad day, and usually I call the nurses and I said, call my wife, I will be late this evening. try to obtain some room space with a 1.0 or 1.2 balloon over a supported wire. So first supported wire, then try to get some room space in the artery. Test the lesion with the 1-1 semi-compliant balloons and gentle nominal pressure. If you get a dog bone and no increase in lumen diameter, as one case, if you have a dog bone but somewhat increase in lumen diameter, is a different animals. So in case one, you obtain some room. GTO balloons, high pressure. So I started with the 1.0 and then I increase. In case 2, I tested the lesion with the semi-compliant balloons, a very gently, careful dilation. If there is a dog bone but no increase in luminal diameter, I use an NC balloon and then a scoring balloon. If I have no increase in diameter, I have to wait or defer for Rota IVL before stent, or in case of stent is an expansion. If you get a dog bone and somewhat increase in luminal diameter, I try to get a stenting high pressure and use an undersized OPN high pressure balloon. And then I had the choice to, again, to finish the procedure or defer or wait for another device such as a Rota and IVL. Just some, this is not a recommendation, it is not supposed to be comprehensive, it's just my view to what to do when I cannot have anything more than some balloon and some stent. This is a case, previous case, so we wiring with a filter STA and microcatheter because no wire was successful before. We we put a balloon with a marginal branch and to have some force more to push the balloon and the equipment. Then we try to obtain some room with an over wire 1.5 balloon, and then we change for a supported wire. So we test the lesion, some dog bone, but the artery demonstrates some increase in luminal diameter, at least on angiography. Then we use a scoring balloon 2.5 for 15. And then we use a guide liner, high dilation stenting, and you see here that we get some intramural hematoma, but we were able to cover with an Orsiro 2.75 for 40 millimeter, and we finished the procedure. So the procedure was finished in that way, and we did not have the necessity to the need for defer the patient. This is a case of a severe calcification of proximal LCX. We touch the lesion with a semi-compliant balloon very gently. The balloon has the dog bone, some increase in space, so we use a scoring balloon, 2.5 again. And then we wait for IVL because we felt that probably we cannot put a stent and dilate it properly. So with the IVL, we perform 3 cycles at 5 cycles, sorry, at 10 impulses each, and then we put the stent and the procedure is finished. So as final remarks, and I save some times for discussion, Rota and IVL are nowadays essential to start an interventional cardiology program. So if you are going to open a program of interventional cardiology anyway, probably is a good option to have such at least these 2 devices. Sometimes, in particular during this day of delaying cath lab supplies due to global slowdown in production, you have to be prepared to deal with calcium anyway. So even if you have prepared and you order your device and you are awaiting your device, probably at the time when you have a case that you cannot defer, you cannot wait, and you have to be prepared to do something. A good strategy would be to do your best avoiding complication and then to wait or to defer for center with roto IVL. As essential is to fix at bed the vessel, avoiding vessel rupture. Doesn't matter if you have to wait 15 days for having the proper devices. All the knowledge from any armamentarium, including the CTOs, can help. So be flexible. Then, when available, IVL or ROTA can help in correcting vessel preparation or stent under expansion. Thank you so much.
So, you were expressive as always.
What?
You were expressive, expansive as always.
Yeah. It's my habitus. I mean.
Yes. So, actually, I think that the most important point is the last one, that you should be prepared what to do if you don't have rotablator or IVL, or as I will show tomorrow on the nightmare session, when the rotablator do not pass, because there are such cases. One of those cases I made in live in Russe. Valery was in the panel, and sometimes it happens, and you have to have in your hand strategy what to do. And probably at that point, the knowledge of CTO techniques helps a lot, actually, because you have to switch from going through the lumen to the techniques of subintimal tracking and so on. Valery is reacting here.
That's an option, but really this is a very different topic because if you got subintimally, there is no, very often you cannot predict that you can go into the real woman after that.
I think that because the audience is mixed. I mean, we have some world experts and we have some young people. The message is to do the best without killing the patient. So possibly, unless it is your grandfather. And but anyway, to be prepared to do something. If you get, STEMI patient, you have to treat it. You cannot defer, you cannot wait. The lady was suffering, so you can provide some kind of treatment. It's not necessary to have immediately the best treatment you can have. It's good to, if you don't have anything more, it's more than good to have an acceptable result, give some flow, give some pattern vessel, and then to wait to defer for other device. So my point of view is to take it not easy, because it's not easy, but take it fairly simple and safe, and then just maybe that you are lucky because you are pry a lot during the procedure. Usually I pry before, during, and after, but I don't know if there is a recommendation for the guideline for this. And then you wait if you not be able to do anything more. We wait for the last case 15 days. The result was shitting, but there is some flow in the artery, so we wait 15 days. The device arrived, and we put the device, and the patient is okay. So why not?
George, what do you think about this? When you don't have ROTA or IVL, do you hear us? Maybe we still don't have connection.
He was praying. So.
Yes. Some other comments or questions? If not, thank you. Please join to us. Gianluca, join to us. And I would like to invite Dr. Alexandrov to show us an illustrative case for coronary IVL. I'm waiting impatiently.
Thank you. After Professor Rigatelli, I know that I won't be interesting for you, but I'll try. My introduction slides, most of them have already been shown. But okay, calcium is one of the most vicious enemies that we have in the cat lab, and we know that the more calcium we have, the worse results we have because of under stent expansion, because of not able to deliver in the stent, because of the complications that we can have in stenting calcified lesions. And of course, the therapies that are useful in the calcium has to maximize the result in the artery and minimize the risk of complications. One of the things that we can use is the intravascular lithotripsy that Dr. Rungi marvelously explained, so I won't stop in this matter. I'll just go to the case. It's a 73-year-old male with stable angina that was referred to our hospital from another one with an LAD CTO and severe osteo LAD stenosis and some distal left main disease. You see a patent right coronary artery with some disease, but we did a functional assessment and it was not significant. You can see on this slide that it's very calcified left main and LAD. This is the anatomy that we have to deal with. It's very severe, not very severe, but significant osteo-LAD lesion with some calcium and disease on the distal left main and short but very calcified occlusion of the LAD. A relatively easy wiring of the occlusion, not a big deal. It's a short occlusion, but of course then the problem started. The microcatheter, as you can imagine, couldn't pass the occlusion. We tried to do a balloon dilatation with the support of a very deep guide extension, but the balloons ruptured just by passing through the occlusion. We weren't able to even put some pressure on the balloon. Just by passing, the balloons ruptured. So the only option that we have was to try to advance a rotowire through the occlusion. Of course, as I said, the microcatheters wouldn't pass. So we pull out the CTO wire, then prayed, as Dr. Rigatelli said, and then were able to pass with the CTO wire. 125 burr was able to cross, but not very easily. But finally, it did cross. Okay, I skipped the crossing. Afterwards, a standard balloon predilatation with a non-compliant balloon on a very high pressure over 24 atmospheres, and putting one stent and post-dilated it with a 3.5 balloon. With such calcium, we decided not to risk with the osteo-LAD. So we decided to use a shockwave balloon, 3.5, 12 milliliters, 12 millimeters. We did 80 shocks. That was the maximum that balloon could do, but as you can see on the last last image, it still has a dog. It's still not fully expanded. Of course, we did post dilations with a non-compliant balloon and a scoring balloon, but that was the result that was maximum that we could achieve. So we decided some tips and tricks for the osteo lesions. When you do a shockwave balloon, that it's a good idea sometimes to put a body wire, and sometimes it's good to move the balloon between the different sessions, 1-2 milliliters forward or backward, just to be able to put the sonic energy from a different angle to the calcified lesion. So we decided to put a stent, and as you can see, after, of course, final kissing balloon inflations and a lot of post-dilatation and 3 pots with a 4.5 balloon, the result, it's acceptable, but as I can say for myself, it's not really perfect. But we left it this way, and this is the control angio after 10 months. It's still the same result. The patient has no restenosis in the osteo LAD, which is luck for him and luck for us. Thank you very much for your attention.
Congratulations for this case. What was the size of the pod balloon?
4.5.
4.5. Because it seems that and the stent in the LAD was 3.5.
Yeah.
Because it looks a little bit bigger, I don't know, just maybe it's a...
It's an IVUS guided procedure. I don't have the images, unfortunately.
Okay, and you made an IVUS finally?
Yeah, it was underexpanded.
Underexpanded?
Yeah, but with a good minimal lumen area. But some struts were not fully expanded.
Okay, lovely.
But what to do, as I have no idea what to do in this case.
No, it's...
I have idea. If you have cutting balloon, that's the right place for cutting balloon.
Yeah, but I didn't. I
This,
had a
this
scoring balloon.
osteo LED, yes, I know, but that's the place for cutting balloon in such situation, and we will maybe obtain optimal result. But still, it's acceptable. That's very good.
Sometimes dilating a balloon proximally to the lesion with a distal marker inside the with a larger balloon. I mean, not even 5 in this patient, because this left main looks like a 5 millimeter for me, just visually. Maybe I'm wrong, but it looks like a 5.0 left main, and in some cases it works because it makes a dissection proximally, which extends, and this moves the plaque distally. But anyway, this is an excellent case, very good. Just I think that you obtained the maximum possible in this situation.
Just a remark. I don't know if you done or not, but when you inflate the shock wave, the nominal pressure 4, no? The working pressure. But after the first cycle at 4, you can increase the pressure at 5 up to 6 to try to gain some space more for delivery or ultrasound. Sometimes it works, and you can even do better in terms of fracturing calcium, whatever.
Yes, this is important point, what Gianluca said, because sometimes if you don't have very firm contact between the balloon and the vessel wall, you cannot achieve the maximum from the balloon. But, you know, it's difficult to judge now. It's easy to judge now, and it is very difficult to make during the procedure. So I think that
that's why I just wanted to show this case that it's not a failure, but it's not a perfect case. And you can see how modern technology can fail sometimes.
Yes, just we sometimes we have to keep in mind that there are factors which are not depending on us, and we should not be too much aggressive. We have to be aggressive, but not too much. It's interesting that I'm saying that, but for everybody who knows me, but maybe this is coming from experience.
You are getting older.
Yes, I get older. Yes,
More quiet.
You're right. Yes.
More quiet.
Yes. So thank you so much.
Thank you.